Perfect. All right, we'll get started, everybody. Welcome to Grand Rounds on this Thursday, November 4th. Guys, quiet, please. So just one announcement from Dr. Mormon to start things off.
Actually, a couple announcements from Mormon. Every now and then you get to celebrate things, and I want to celebrate a couple things that are important to our program. First of all, you guys know we're always proud of you as residents, but this past week, you knocked it out of the park. So we had Oscar Miller Day, and you know, the big award at Oscar Miller Day is the Basil Boyd Award for the top paper. And you guys may not know this, but these papers are solicited from the whole Southeast, from the tip of West Virginia all the way down to Louisiana. And so a lot of papers are submitted, a lot of competition, but we had 2 finalists for that out of the 3 that were picked. So I want to congratulate Randy McKnight and Kelsey Coe for being finalists. And then for her paper on hold the antibiotics, perioperative antibiotics are unnecessary in the treatment of pediatric supracollar humerus fractures, Kelsey Coe took home the bacon for the top award. So congratulations to Kelsey, wherever you are, Kelsey, for that award. And also congratulations to her mentors. I think one's behind me, and who we're working with her on this paper. The faculty are really invested in your development, and not only as clinicians, but also as researchers, and helping to move the needle with innovation. And so thanks to them. But that wasn't all. So then we have the North Carolina Orthopedic Association meeting on Saturday. And of the 7 award papers, 5 were carried off by either Legacy Atrium or Legacy Wake Forest residents. And I want to congratulate Eric Seacrest as being one of them. Depression screening and behavioral health integration in an orthopedic trauma clinic. And also your mentors in the trauma service. But congratulations, Eric. And then in the shoulder, Joseph Jolissaint, who we're going to hear from in a minute, had a great paper on opioid-free shoulder arthroplasty is safe, effective, ... with Natty Hammett, I'm assuming was your mentor for that. And so congratulations to you, Joseph, for that paper. And then finally, on the sports medicine topic, Brad Young, it's Brad in the back here, the distal clavicle A-frame morphology on computed tomography. So congratulations to you and your mentors. I assume that was probably PC and Natty who were your mentors, or maybe Rebo on that? Dr. Connor, okay. Well, congratulations to Dr. Connor, and appreciative of his mentoring. So, you know, I'm not a research geek just to be a research geek, but what I'll tell you is that when you do a project, you learn much more than just your topic. You learn how to critically read an article and how to assimilate information into your practice in terms of how it can help your patients. So it's really important to do these things, and congratulations to all of you all. The other thing we celebrate is a great North Carolinian and a great orthopedic surgeon in Charlotte, Oscar Miller. And the picture you see here on the screen has to do with an unveiling that Glenn Gaston and I did at Oscar Miller Day to honor Oscar Miller. And you all may know that one of the things we're working on is a celebration of the legacy, history, and tradition of orthopedic surgery in Charlotte that we display on our Wall of Fame. So Oscar Miller, fittingly, will be one of the first of those to go up. And this is a portrait that's an original work of art commissioned by Fred Marshall, who's a noted artist. And we've got some others that you all have seen up there. Bossy and Hanley are up already, and we have a few more to come. But we wanted to celebrate Oscar Miller. But I bet you all probably didn't even know who Oscar Miller was other than Oscar Miller Day. But he was an orthopedic surgeon who was a real true national leader. He was president of the Academy in 1943. He grew up as the oldest of 10 children in North Georgia, went to what we now call Emory. Some of y'all are from down that way. And then he had a distinguished career in the military before coming back to lead the North Carolina Orthopedic Hospital for Crippled Children in Gastonia. And he set up the Crippled Children's Network that all of the big programs in North Carolina are involved in. We were involved in it at Duke. I remember going out to Wilson and Ahoskie and the other clinics with our mentors, and that was all set up by Oscar Miller. But he also had a legacy and tradition of education and research. He had over 170 publications. I mean, 170 publications is totally remarkable today, But can you imagine in the 1940s what it would be like to, Tom, you think you could have done 170 back in 1940? Of course you have now in our time, but so anyway, a great person that we celebrate, and just an opportunity to celebrate Charlotte Orthopedics. So I wanted y'all to know about that. Thank you.
All right, well, we will get started. Thank you, Dr. Mormon. Thanks to all the residents too for their participation, and Oscar Miller, and then NCOA as well. So our first CME color will be green. Our first talk this morning is by Dr. Jolissaint on complex reconstruction of acetabular defects. Yeah, but up there. All right.
Get on Zoom, whoever's on the Zoom. Good morning. My name is Joseph Jolissaint. I'm one of the PGY3 residents here, and the title of my talk this morning is Complex Reconstruction of Acetabular Defects, Trauma, Tumor, and Revision Arthroplasty. I'd like to start with a few cases, as always, to frame our discussion. First, Mr. RM. This is a 75-year-old gentleman with a past medical history of prostate cancer, treated with XRT in 2011. He subsequently had worsening right hip pain over 10 years, and biopsy demonstrated diffuse large B-cell lymphoma. He underwent radiation for his lymphoma, and unfortunately, the radiation weakened his bone so significantly that he subsequently developed the right femoral head AVN, as well as pathologic fractures of his superior acetabulum and quadrilateral plate. And as you can see, he has associated protrusio. Next, Mr. MM. This is a 63-year-old male with history of hepatitis C, Charcot-Marie tooth, and chronic left prosthetic hip joint infection. His index surgery was in 1992 when he had a left total hip. That was revised in 2013, and unfortunately, his revision was complicated by an MSSA infection. He was treated with IV Ancef and subsequently underwent resection of his acetabular component in March of 2019. However, that was only a partial resection as his press-fit femoral revision component was retained. He had another partial spatial exchange in August of 19, and he was seen at Duke and subsequently referred to our clinic, given the complex nature of his problem and the need for more specialized expertise. As you can see, he has Prokopowski type 4 defect of the femur and a Prokopowski type 3B defect of the pelvis, and we'll discuss what that means. This is all in the setting of a likely active infection, given that femoral component was never removed after he developed his prosthetic joint infection. JS, this is a 54-year-old male with a past medical history of homelessness, alcoholism, and a right total arthroplasty in 2002 after he sustained a femoral neck fracture in a motor vehicle crash. Unfortunately, he's been homeless over the past number of years and struggling with alcoholism, so much so that when we saw him, he had an indwelling PIC so he could receive thiamine and folic acid. He had numerous trips to the ER prior to this radiograph being obtained, and as you can see, he has massive osteolysis in all three zones around his acetabulum and a large bone defect. Finally, last but not least, Mr. MB. This is a 47-year-old active, healthy male Navy SEAL who was involved in a motorcycle crash. He's well known to our orthopedic trauma service at Maine because on arrival, he had a segmental tibia fracture, as well as this right femoral neck and head fracture dislocation associated with a posterior wall acetabulum fracture. Bony acetabular defects represent an extremely complex reconstructive challenge. Additionally, there is a very broad etiology, which contributes to the surgical complexity of the problem. And as I have illustrated with the prior cases, acetabular bone defects can result from trauma, tumor, and the sequelae of treatment, and complications of arthroplasty, including osteolysis, infection, and aseptic loosening. When evaluating acetabular defects, you want to start, as with any orthopedic problem, using plain radiographs. And you really want to obtain not just an AP and lateral, but also Judet view radiographs. You should evaluate for migration of the cup, the amount of ischial osteolysis, teardrop osteolysis, any visible fracture lines, medial migration of the inferior hemipelvis, and obturator ring asymmetry. And the reason obtaining a Judet is important is because obtaining Judet views in addition to your AP and lateral radiographs can increase your sensitivity of identifying pelvic discontinuity. Martin et al. Reviewed 133 patients who underwent acetabular revision for pelvic discontinuity and found that pre-op evaluation with a combination of an AP pelvis radiograph plus a true lateral plus Judet films allowed for identification of pelvic discontinuity in 100% of patients. However, with that being said, Safir et al. Did a study where they sequentially removed bone from a cadaveric model and had orthopedic surgeons quantify the amount of bone loss and found that, as many things, we tend to underestimate our bone loss, just like our blood loss in surgery. So in addition to plain radiographs, CT can be extremely helpful and informative in quantifying the amount of bone loss as well as the location. And later in this talk, I'll illustrate the depth of how valuable a tool like CT imaging can be in this problem. So as one can imagine, preoperative planning is essential to choosing the appropriate surgery, implant, and fixation, and therefore one needs to objectively define the nature of the defect to assess remaining acetabular bone stock and bone quality. Two widely used classification systems that provide detailed anatomical information are the AAOS system and the system of Prosky et al. And in general, the larger the defect, the more challenging the acetabular revision. The AAOS classification, as described by D'Antonio and Associates, identifies the pattern and location of bone loss, but does not quantify the defect. It's based on two basic categories, segmental and cavitary defects. A segmental defect, or a type 1 defect, is defined as complete loss of bone in the hemisphere of the acetabulum, peripherally or centrally. An essential segmental defect involves loss of the medial wall of the acetabulum. A cavitary deficiency, or a type 2 defect, is defined as volumetric bony loss of the acetabulum with an intact rim, and these defects can occur peripherally or centrally. Medial cavitary defects involve loss of the bone centrally with an intact medial wall, as in most cases of protrusio, and the peripheral defects in types 1 and 2 are further divided by anatomic position. And combined segmental and cavitary defects, classified as type 3 defects, occur frequently. These defects can be caused by failed migrated prosthesis, as well as those seen in developmental dysplasia. Pelvic discontinuity would be considered a type 4 defect and is an unusual condition in which the superior pelvis and the inferior pelvis are separated. And typically this occurs through a transverse acetabular fracture, through weak and deficient bone. Finally, type 5 is orthodesis. And although this classification system does define acetabular defects, its major flaw is that it does not address the management of those defects. So the Prosky classification system is based on the AP pelvis radiograph, and it uses 4 separate criteria to determine the classification: superior migration of the cup, the amount of ischial osteolysis, the amount of teardrop osteolysis, and the position of the cup relative to Kohler's line. The Prosky classification system is based on the severity of bone loss and on the ability to obtain cementless fixation for a given bone loss pattern. Type 1 is minimal deformity with an intact rim. Type 2A would be superior bone lysis with an intact superior rim. 2B would be an absent superior rim with superolateral migration. Type 2C would be localized destruction of the medial wall. And then type 3 are massive defects. And this is where, type 3A would be bone loss from 10 to 2 with superolateral cup migration. And type 3B would be bone loss from 9 to 5 with supremedial cup migration. And notably, this was originally described in the setting of revision arthroplasty. I've presented several cases that aren't necessarily revision arthroplasty. However, we can use this classification to help lump categories of bone loss and potential for surgical fixation methods. When managing acetabular bone defects, principles of reconstruction include restoring the anatomy. This means ideally placing the cup at the hip center of rotation. However, as you will see in larger and more complex cases, this may not be possible. Next, achieving strong mechanical stability and fixation. And this is an important point I want to make. If you can achieve strong mechanical stability with a jumbo cup at a high hip center, for example, that's preferable over moving to a more complicated fixation strategy simply to restore the hip center motion. In the setting of massive acetabular bone loss and or pelvic discontinuity, principles include restoration of continuity between the ilium and ischium and restoration of bone stock with autograft or allograft. In terms of surgical management, there are numerous ways to manage acetabular defects, and the treatment of choice strongly depends on the amount of bone loss, whether or not fixation can be achieved with a cup, and whether or not pelvic discontinuity exists. Some of the options include a standard or jumbo cup with screws, jumbo cup with augments, a cup cage construct, and a custom triflange. And again, as I mentioned in the last slide, for the first line fixation, we should try to get a pinch fit or a press fit, even at a higher hip center, prior to moving on to other fixation strategies, such as augments or cup cage constructs. Well, how do we decide the appropriate surgical management? Well, I've already discussed the surgical principles of fixation, and in addition to those, Dr. Prosky and others have published suggested treatment algorithms, which can be seen here for acetabular defects. So stable fixation can be achieved when using cementless acetabular components and screws if the contact of the component with the host bone is more than 50%. And so, for example, if we had a patient with an acetabular defect in hip center within 2 centimeters from the native hip center, and if you're able to achieve a press fit, then you can use a hemispherical cup. If the defect is lateral to Kohler's line, you can use solely a cup and screws. And if you have a patient with protrusia, you can treat with cancellous allograft in addition to the hemispherical cup. But what about the patient where the hip center is greater than 2 centimeters from the native hip center? As I stated earlier, the ideal scenario is achieving a press fit with a spherical defect. You can use a jumbo cup, and even in the oblong defect, you can oftentimes achieve a press fit with a jumbo cup at a high hip center. However, if you aren't able to achieve that pinch fit with an oblong defect, you can also utilize a jumbo cup with a superior augment, for example. But what about the patient where there is such a significant amount of bone loss that we think biologic fixation isn't attainable with a hemispherical cup? Well, there are numerous options in addition to the augments that I've just mentioned. In patients without pelvic discontinuity, you can also use cancellous or structural allograft with a cage or a triflange construct. In patients with pelvic discontinuity, you can use a plate with cage and allograft, a triflange. The distraction technique, where you put in a cup well larger than the size reamed in an attempt to compress the discontinuity. And I've also put on the slide bulk structural allograft. However, I've striked it out because this is mostly historical and not typically a technique used. Suffice it to say that anytime there are numerous treatment options, it's typically because the problem in and of itself is extremely challenging with diverse etiology and presentation, and there's no perfect solution which would work for every defect. So a treatment algorithm for a complex surgical problem based on a classification system categorized from an AP radiograph was helpful 20 to 30 years ago when CT scans were difficult to obtain, expensive, and had prohibitive amounts of radiation. But one can imagine that in modern day medicine, in the year 2021, more information is better. Additionally, you could imagine that it would not be a good day if your surgical plan and treatment algorithm was based on an assumption of a type 2 defect from an AP radiograph, which turned out to be a type 3 defect intraoperatively. And finally, there's a wide breadth of defects, even a wide breadth of type 3 defects, all of which can be seen above. A very wise man once introduced me to the fairing classification, which can be appreciated here. On the left, bad; in the middle, really bad; and on the right, really, really bad. So in today's society and with modern day medicine, we should use the diagnostic tools available to accurately assess massive acetabular bone loss. CT scans today are cheaper, more easily obtained, and have decreased radiation. And given the surgical complexity of the problem, a CT scan allows you to more easily identify and quantify the amount of bone loss preoperatively, and even to customize implants to the bone loss and plan screw trajectories. So in managing acetabular defects, CT removes guesswork, facilitates intraoperative planning, minimizes intraoperative surprises, and facilitates intraoperative dissection. For example, let's say this patient walks into your office and you're trying to decide what surgery would be best for him or her. Well, as the astute doctor you are, you order a CT scan with 3D reconstruction, and on the right, I'm sure you can see and really appreciate the amount of bone loss, which you may not be able to achieve or appreciate simply with that radiograph. And that digital 3D reconstruction can then be turned into a physical 3D reconstructed model, and evaluating this model in real time can help you plan what reconstruction option would work best for the patient and best for you in your hands. And here's how that can translate into practice. You can see the AP radiograph on the left, how that translates into a CT 3D reconstruction, and how a custom triflange implant can be constructed and utilized intraoperatively to treat the patient. Now that we've discussed classification systems, diagnostic tools, and the various surgical options, let's discuss some of the results with those surgical options. So stable fixation can be achieved using cementless acetabular components with screws if the contact of the component with the host bone is more than 50%. And implants in the optimal revision setting have shown excellent long-term survivorship, ranging from 95% to 98% at 10 years, as can be seen in these studies. Whedon et al. Evaluated 134 hips and published their results in JBJS in 2013. They found that 127 and 95% of the 134 hips treated with cementless acetabular components and screws were stable and clinically successful. The other 7 hips, or 5%, were considered to have failed, and 5 of those 7 hips failed because of an infection, 2 because of aseptic loosening. Notably, 5 of the 27 hips, or 20%, with a Peprosky type 3A defect, which is a defect in which 30 to 50% of the host acetabulum is missing, failed, indicating that in larger defects that this may be a suboptimal method of fixation. Delaval reviewed 138 consecutive acetabular revisions done with the hemispheric cementless acetabular component and multiple screws, and published their findings in Core in 2004. And they found that survivorship of the component was 81% at 15 years if we considered revision for any reason, However, it was 96% when revision for loosening or radiographic evidence of loosening was considered as a secondary endpoint. And they concluded that cementless acetabular revision provides durable results at 15 years with a low rate of failure for loosening. Another study published in JBJS in 2005 found that the 15-year survival rate of the metal shells with failure defined as revision because of loosening or as radiographic evidence of loosening was 97%. Suffice it to say that revision total of arthroplasty with a cementless acetabular component and screws in this kind of ideal revision setting has been followed by excellent component survivorship at 15 years. But what about those patients where the bone is more significantly deficient? As we discussed, one option to address the bone deficient acetabulum is TM augments that can be used to fill bone defects and give support to the acetabular component. Delgaizo et al. Reported results in 37 hips with Poprosky type 3 defects. All were treated with the TM cup and augments, and at an average follow-up of 60 months, the revision rate for aseptic loosening was 3%. One patient developed aseptic loosening, the acetabular reconstruction requiring revision. 7 other patients required further surgery for a femur fracture, acute infection, or recurrent dislocation, and that led to an all-cause revision of 22%. 35 of the 37 hips had no or occasional pain at final follow-up, and mean Harris hip scores improved from 33 pre-op to 81.5 post-op. Bogomisian et al. Reported good results in the revision of type 3 and 4 defects with a cup and augment strategy. In 34 hips at a mean follow-up of 64 months, the aseptic loosening revision rate was 3% if you remove pelvic discontinuity. Their patient cohort consisted of 18 patients with a minor column defect, 14 with a major column defect, and 2 with pelvic discontinuity. A total of 3 patients failed because of aseptic loosening. However, one of those patients received 2 augments, and the other 2 failures were in patients with pelvic discontinuity. With clinical or radiologic failure due to any cause, the 5-year Kaplan-Meier survival was 87.7 with 19 patients at risk. And at the same interval, the Kaplan-Meier survival rate with aseptic loosening as the endpoint was 91.1%. And their conclusion was that good clinical and radiologic results can be expected for bone deficient acetabula treated by a porous tantalum cup and augment, but for pelvic discontinuities, as those 2 patients in their study, this may not be a reliable option. In 2016, Amenabar et al. Investigated the cup cage construct for large acetabular defects and pelvic discontinuity, and they evaluated 67 cup cage procedures with an average follow-up of 74 months. The 5-year Kaplan-Meier survival rate with revision for any cause representing failure was 93, and the 10-year survival rate was 85%. The Merle-Debon Postel score improved significantly from a mean of 6 pre-op to 13 post-op, and 4 cup cage constructs had non-progressive radiological migration of the ischioflange, however, remained stable. They concluded that the cup cage construct is a suitable choice to treat chronic pelvic discontinuity. It also remains a reliable option for the treatment of severe acetabular bone defects if stable fixation cannot be obtained through the use of a trabecular metal cup, with or without augments. And a newer patient-specific treatment option, which provides a solution for complex bone-deficient cases and which has gained a significant amount of traction as of late, is the Triflange construct. Christie et al. Evaluated 67 Triflange constructs for combined deficiency in 39 hips and for pelvic discontinuity in another 39 hips. At an average of 53 months, no Triflange cup had been removed, and Harris hip scores improved from a pre-op mean of 33.3 to a post-op mean of 82.1. Radiographically, there were 2 patients with incompletely healed discontinuities, but both were asymptomatic. And reoperation for recurrent dislocation did occur in 6 patients with a rate of 7.8%. However, again, the Triflange cup was maintained. They concluded that the Triflange cup offers an alternative method of repair that reliably provides pain relief, initial implant stability, potential long-term implant stability, and pelvic stability in cases of discontinuity. In core in 2012, Taunton and Faring et al. Reviewed 57 patients with pelvic discontinuity specifically, treated with revision total of our arthroplasty using a custom Triflange. Their average follow-up was 65 months, and they found that 56 of 57 or 98% of patients were free of revision for aseptic loosening at their last follow-up. 54 or 95% of patients were free of revision of the Triflange component for any reason. 46 or 81% had a stable Triflange component with a healed pelvic discontinuity. The average Harris hip score was 74.8, and they also evaluated the costs of the custom Triflange compared to other options and found that the cost of a custom Triflange and a trabecular metal cup cage were equivalent. They concluded that in this group of patients with osteolytic pelvic discontinuity, Triflange implants provided predictable fixation at a cost equivalent to other treatment methods. Well, we've discussed short-term results for custom Triflange implants, but how are patients doing greater than 5 years after this complex surgery? In 2017, Gladnick and Fehring et al. Evaluated the prospective data on 73 hips from 2 high-volume tertiary care centers, and they had a minimum 5-year follow-up and an average follow-up of 7.5 years. And they found that 15 of the 73 Triflange components, or 20.5%, were indicated for revision during the follow-up period, which included 6 for instability and 8 for infection. 12 of 73 patients, or 16%, underwent reoperation for reasons other than failure of the Triflange. And the median Hoost Jr. score at midterm follow-up was 85. Now, only 1 of 73 implants was determined to be radiographically loose at midterm follow-up. And they concluded that custom Triflange reconstruction for severe acetabular deficiency is a viable option. However, as we know, with significantly complex problems, complications are common and significant challenges remain for those that do fail. Now that we've discussed various acetabular bone defects, treatment options, and clinical results, and now that we have a good frame of reference, let's return to our cases. Mr. RM, our 75-year-old patient with a right hip AVN and acetabular pathologic fracture and protrusio, in the setting of radiation for both his prostate cancer and his diffuse large B-cell lymphoma. As can be seen, not only does he have bone loss and pathologic fracture, but he also has poor bone quality and irradiated dead bone. Mr. RM underwent a complex total of arthroplasty with a cup cage construct given his poor bone quality after radiation. The cage provides initial stability to the cup by shielding it from mechanical forces, and this allows bone to grow within the porous TM cup and biologic fixation to take place, giving the entire construct its long-term stability. Going back to our 63-year-old male with history of Hep C, Charcot-Marie tooth, and chronic left prosthetic hip joint infection with numerous surgeries, as well as that Peprosky type 3B defect. He subsequently underwent a 2-stage revision. Stage 1 involved resection arthroplasty with articulating antibiotic spacer and cage, IV antibiotics. And once his infection was resolved, he underwent a Triflange and total femur construct, which can be seen here. JS, our 54-year-old male with a past medical history of a total of arthroplasty in 2002 after a femoral neck fracture. He underwent a hip aspirate to rule out infection, which was negative, and was subsequently medically optimized. He then underwent revision with a large gription augment and shell to fill the significant bone void. Finally, Mr. MB, our 47-year-old active healthy male Navy SEAL, was involved in a motorcycle crash and sustained this femoral head and neck fracture dislocation, as well as a posterior wall acetabulum fracture. Well, he had his segmental tibia fracture fixed by the trauma team and then underwent left total of arthroplasty with primary components for his left femoral neck and head fracture dislocation, as well as his posterior wall fracture. So in summary, acetabular defects are a complex problem with a broad etiology. There are numerous surgical options, and in planning, you should use the diagnostic tools available to you in today. Finally, refer. As I said at the beginning, these cases are complex and challenging, and even for those trained in joints, these patients would be best treated at a specialty care center such as this, where we have surgeons who take care of more cases like this in a week than many will see in a career, and where we have consolidation of skilled care, research, and established treatment protocols to give the patient the best possible care. A big thank you to Dr. Fehring, Dr. Otero, and Dr. Springer for their help and assistance with this talk. As always, I'd like to thank my great support system, my wife, kids, and Rockstar co-residents. With that, we'll take any questions.
Great talk, Joseph. They're very complete. And I think one of the issues here is we're not seeing these problems as frequently as we used to. Modern plastics, osteolysis is starting to become a thing of the past. Did a nice job talking about the classification systems. Pretty much outdated. In the mid-90s, when osteolysis, we only had plain radiographs. Now you can call up your rep and get a CT, and within a week or two, you've got a model that you can look at and really make a decision based on real anatomy. They can turn that into a piece of plastic, really plan. So most of these severe acetabular problems handled with a general cup. We go out to augment some of the more sophisticated things. Still relatively rare. Getting the joint line perfect, knees and getting the hip center perfect in hips. Probably is a lofty goal from a podium. In reality, if you can get a jumbo cup up a centimeter or two, like contact with bone, that's perfectly comfortable. Efficient surgery and better for the patient.
Awesome, thanks.
Surgeons are happy about that.
Yeah, I think you did a wonderful job, Joseph. Thank you for presenting. And Dr. Grant's absolutely right. It's where you see massive osteolysis. I probably see a whole complexity of maybe real prosthetic osteolysis from quality every couple of months. But the diversity of problems continues to increase because arthroplasty is more frequent. Different age groups, different indications. And so, but what you presented is a great framework to plan any type of surgery. And I think that's the most important thing is that you plan correctly. You can't over plan fellowship, execution. The most important thing though is just facilitating success after surgery. So that's protecting the patient from harming themselves, allowing biology to occur, preventing infection. There's so many things that we can go on into. You did a really great job presenting complex diverse cases. So I think that's the option.
Yes, that was a great job. Sorry, to go ahead.
Now, I was going to ask something pretty basic, and you know, on the in-training exam period, they ask us about GA views, what you see.
Mhm.
Do you mind walking through with your colleagues
Yeah,
what you see on the iliac versus an obturator?
yeah. So my favorite one is Nick Johnson likes to use the acronym Iowa. So the iliac oblique is the wall, wall anterior wall and posterior column, and then the obturator will be up the reverse. Yeah,
So remember that, guys.
Iowa.
We'll see it again. Sorry, Brian.
No, that's okay. Just that was great talk. It was difficult subject. I wasn't sure if you were lip syncing your video.
Oh.
I think the top point probably 75% of these defects that we do now we can treat with jumbo acetabular cups and multiple screws. And the big reason for that is the biology hasn't necessarily changed, but the materials that we use have changed significantly in the past probably 15 or 20 years, going from using two-dimensional, subtractive manufacturing type cups to now three-dimensional, 3D printed and cups. So one of the things we see is that, in those historical cups where you needed, I don't know, maybe 60% post-bone contact in order to get ingrowth, some would argue that maybe you need less than 50, maybe even just 30% of post-bone contact to get some of those, 3D quartz metal shells. And I think that's even true now in irradiated pelvises, right? Where historically it was a cemented cup because you had no biology. There's pretty good data to suggest now that we can use these highly 3D quartz metal cups that are 3D printed, a really excellent biological fixation with very low amounts of post-bone contact.
Awesome. Thank you.